I want to take a moment, and I will take a moment again to introduce a new name and welcome our newest project coordinator, Caroline Somerville, who's on the call with us today. I'm really excited to have her as part of the team. And we have been a very fortunate perinatal quality collaborative. We've had so many wonderful project coordinators who just slide right in and fit right in with the team and get to work so well and so seamlessly. And Caroline has been no exception, and we're really excited and thrilled and honored to have you as part of the team, Caroline. All right, so for everybody joining, if you could put your name and your organization into the chat, we appreciate it, and we can go ahead and get started. So as usual, this is our Penguin Maternal Equity Bundle webinar. We're optimizing racial equity action across Massachusetts. This is our team webinar number 9 for this year 1 of the Equity Bundle. And today we'll be talking about family engagement, and we have Brace Gibson, who's one of our guests, to speak about this work that she's doing at the CPQCC, which is Colorado. I apologize. I live in the state of California, so please forgive me, Brace. The Colorado Perinatal Quality Collaborative. We can go to the next slide. As we do with all of these webinars, we'll have some opening comments. Then we'll talk about some data, and then we'll go into our discussion with Brace. We wanted to wish everyone a happy Juneteenth and hope everyone enjoyed the long weekend and took time to reflect on what this means for not just African Americans, but for all Americans, that we have policies in place and we've been able to move into a space of freedom for everyone, and how we can continue to support the advancement and progress of all people, particularly related to their health and wellness where it comes to this particular project. Happy Juneteenth. Next slide. So as usual, can you place your name and your institution into the chat? Everyone I see is already muted, but if not, please mute yourselves when you're not speaking. You can place questions in the chat. Also, all sessions are recorded, and so these are available on our Penguin website, so you can go back and see any of our archived sessions in the webpage, on the webpage, and many of these sessions are available for CME and CEU credits. All right, next slide. So as usual, we'll start with our welcome everyone, and we'll go into some data discussion, and we'll go into Brace's conversation on patient and family engagement, which is really key. And as many of you will see in the data, we can go to the next slide, Kaylee, that it's really important to think about how we can include patients and community into the work that we're doing. We're doing that with our Penguin Maternal Equity Bundle work group, as well as our Penguin governance for our board, where we have Shaniqua Choice as one of our community members for Penguin. And we have a great representation from across the state, but we're always accepting new faces and folks to join our Penguin Maternal Equity Bundle work group. This is a work group that meets monthly to talk about the bundle and which direction we're going in. So we'll go to the next slide. I want to say thank you to all the members that make this possible. We have 22 participating hospitals. We are going for 5 more. So into year 2 and into the fall, if there are hospitals that you are a partner hospital with or part of your network that you think would be a great addition, if you want to let me and Kaylee know, that'd be fantastic. We'll reach out. We can work with teams to help get them pulled into the bundle in a way that feels seamless, and to help them start to also build an infrastructure and put that in place so they too can have the infrastructure they need in order to support the work to address equity, no matter what the demographic inequity is represented. I will go to the next slide. So here are our bundle measures. We send out surveys to the 22 hospital teams once a month, and they get that survey on the 1st of the month, and all the data is due by the 10th of the month. And then what we'll do is we have all that information put together for you guys. We won't show you all of the outcomes because it's going to take a long time. And when we do that, we'll do that on our September webinar, where we'll go through all the bundle measures. But we've pulled out a few select bundle measures for today that pertain to the conversation we're going to have today. All right, we'll go to the next slide. And if you have any questions or want to add any data that's missed, if you've missed any months, you can always email Kaylee at penguinadmin@penguinma.org to get some support and get started. Okay, let's go into the data. Let's go to the next slide. So for the structure measures, as you guys know, we talk a lot about forming a formal equity team. And we really feel like that's important, not just at the hospital level, but it's the sort of number one recommendation is that we have to have leadership support for the work that we're doing. And in order to have leadership support for the work that we're doing, we need to have a governance within our obstetrics and gynecology spaces that look at our data, that look at our processes, that look at what we're trying to accomplish, and have a group of people who can review that and offer some way forward and have leadership support of that existence. So we're really happy and excited to see of those who are reporting. So for May, the data that's been reported for May, there were 10 teams that reported. So 7 have a formal equity team, 3 do not. But we go to the next slide. The next question related to that is how diverse are the roles for those formal equity teams? And what you can see here that we're really excited about is we're starting to move in the direction of, in April and May, having a team that has a community member as part of their equity work group. And so it's going to be nice to hear what Brace Gibson is going to talk to us about and the work that they're doing in Colorado, because we know that that's a challenge. And we're the beautiful part of seeing the April and May report that we have this person on our work group is to say that if one team can do it, all teams can do it. And we can get there. And we have some ideas at Pinquin about how we can move this forward. We have some funding to support bringing on a family engagement coordinator. Some other PQCs have a family engagement coordinator, but this is to show that this work can be done, is being done, and moving in that direction helps us to really address and support the communities we serve in a more robust way. We've seen the blue is what we're looking for. We want to see all 3 of these segments go in the direction of a sea of blue. And so we know community members probably one of the more challenging. There's just a lot of questions and logistics to really dive into. But for the diversity of roles, we've already seen a sea of blue moving forward where we have a diversity of position and knowledge base within the roles of those that are on the diversity committees, but then a diversity of race and ethnicity. We're starting to see a sea of blue move forward in that direction as well. All right, we'll go to the next slide. And so for our structure measure 5, we also asked about patient-reported experience measures. So we really believe it's important, and we've seen in the data that many believe it's important to understand what people who are receiving care from our hospital teams and our hospital sites are saying about their care. And we're seeing an increase in the number of sites that are showing that they have a PREM in place. And part of the way that we work to support people getting a PREM in place, or teams getting a PREM in place, is to work with Team Birth. And so Team Birth and Pinquin teamed up, and we created a PREM specific for Massachusetts based on a lot of work that's happened. We've presented on that work that's happened in New York and work that's happened in Illinois. And then we adapted that here in Massachusetts. So wonderfully, if you have Team Birth, you have a PREM in place because we're using the Team Birth PREM that we created together. And then other sites are increasing their questions around implementing a PREM. And then another focus for us, we can go to the next slide, is to also lean into health systems adopting our PREM, so that way they can bring it to the hospitals directly. So some of the PREM that people use include the HCAHPS, their own derived hospital patient satisfaction surveys, like the one with Team Birth. Other Press Ganey, Qualtrics are listed among there. And I think that the second one and the last one are both inclusive of Team Birth. So probably those numbers are a little higher for Team Birth. All right, so let's go to the next slide. Now, so some process measures. We have been focused in on structure measures this entire year, and for good reason, because the goal is that we put the structures in place. We have to have our foundation in place to be able to do this work. And so what we're finding is that people are moving in the direction of having those structures in place, and we'll continue that support over the years of this grant. One thing that's interesting is our process measures. So we can go to the next slide. What we're looking at when we look at our process measures, and many of you have seen this, but they are the process measures of both the hypertension and hemorrhage bundles, but with the addition of being by race ethnicity. We do know that in Massachusetts that our greatest delta and our greatest gap that creates inequities among races, or that makes it higher rates for non-Hispanic Black women, is that related to hemorrhage and hypertension. And so here what we see with hypertension in December through May of 2023, and you can see the percentages that NHB treated is the non-Hispanic Black group that's been treated. And so that's in blue, and non-Hispanic white that's been treated, that's in orange. And this is all sites that are contributing data. And in May, we have 10 sites that contributed data. We see that 60% of non-Hispanic Black women in May were treated for their severe hypertension within 1 hour with the appropriate medication, and 65% for non-Hispanic white. There's actually been times when we've seen adding this all together in aggregate will actually show between December and May that the total percentage of non-Hispanic Black actually exceeds that of the total percentage of non-Hispanic white that's treated in a timely manner. And so there's lots of questions that arise from this data. What does that mean? Is this that we're not diagnosing in time? Are we not treating in time? Are people receptive of the treatment? Are people declining treatment? There's a lot to be answered there. So this just showing this information doesn't tell us what's happening and what to do about it next, but it does let us know whether or not there's variation in care. And that's what we're looking for. And that's what your team should be looking for, not comparing yourselves to this, but comparing yourselves, as Dr. Job's words, comparing yourself to yourself months prior. All right, so let's go to the next slide. And the proportion of charts of birthing people with severe hypertension scheduled for a blood pressure check, usually within 72 hours, and for some within 1 week. And we're seeing that there are a number of non-Hispanic Black women who, or birthing people, who have been scheduled for and received their follow-up visit for their blood pressure check. And less so among non-Hispanic White, except for in May, which is a different reporting. So it is hard for us to compare. I do want to say out loud, it is hard for us to compare May to April, for instance, because the number of teams reporting vary across some of these. And so we'll show you in our September wrap up, we'll actually show you the data based on the teams that have consistently reported across time, in addition to all the data that we've received, so that we can start to show some true comparisons. But just wanted to give you guys a preview of where we are with collecting information on treatment for severe hypertension by race ethnicity. All right, let's go to the next slide.
And this is also a preview for next month's webinar. The topic will be these hypertension process measures by race ethnicity. So we're looking forward to that.
Great, and our very own Dr. Ron Iverson will be presenting at that webinar. So without further ado, and to give adequate time, because this is really important for our groups to hear, we're going to hear from Brace Gibson, who is a lawyer in Colorado who works for the Colorado Perinatal Quality Collaborative and has helped them to address healthcare disparities through patient and family engagement. And so we're going to hear Brace talk to us a little bit about lived experience integration. So thank you so much for joining us, Brace. I'm going to turn the microphone over to you.
Thank you for inviting me, Audra and team. To speak about our approach to patient-family engagement as Colorado's Perinatal Quality Collaborative. I am the Director of Policy and Engagement for CPCQC, and the primary focus of this presentation will be on the program that we've implemented to integrate diverse lived experience perspectives into quality improvement initiatives to address inequities in care and reduce disparities in maternal infant health outcomes. Next slide. So I have no relevant financial sources of support or special affiliations to disclose. Next slide. Okay, and we hope that by the end of this webinar, you'll walk away with additional knowledge and tools to create partnerships of care in your work through the meaningful engagement of patients, families, and community members. We hope to highlight the importance of including lived experience experts as part of your formal equity teams and honoring the diversity of experiences that accompany the perinatal continuum of care. Next slide. And Audra did an amazing job, but to further root our conversation today within Penquin's maternal equity framework, as was mentioned, patient-family engagement addresses structure measure 1 of the equity bundle. Hospitals should have a formal equity team that is based in obstetrics or reproductive health and incorporates a diversity of roles, races, and ethnicities, and has a community member representation. So today's presentation will hopefully help to guide you in meeting this measure. Next slide. So first, let's talk a little bit about why community representation and patient-family engagement is important from an equity standpoint. So we know that variation in care and corresponding health outcomes exist. There's really a host of sources of care disparities, all of which intersect and further complicate our efforts to meaningfully and effectively address disparities in health outcomes. And historically, our efforts to address these disparities were contained within the 4 walls of the hospital. But we know that given the sources of these disparities, that approach is not likely to make significant change. And so we really have to step outside of the hospital and work at the intersection of community, patient, and healthcare delivery. Next slide. And so what we now see as the role of the PQC is to help shape and advance health equity through innovative quality improvement initiatives like the Equity Bundle that build alliances and facilitate shifts in practice and in culture through small tests of change that ultimately become transformative. And the PQC can really help guide and support your hospital care teams in making those connections with communities, which is what we'll be focused on today. Next slide. And part of that shift in culture is demonstrated by the way in which we think about quality healthcare, which has generally evolved from a fundamentally paternalistic practice of viewing the patient as external to or separate from the care team, whereby they're merely informed of their condition and treatment options, to a practice of centering the patient in their care, which allows for greater involvement in shared decision-making. But more recently, I'd say there's been some shift further then into thinking and in practicing toward establishing a partnership of care that establishes the patient to truly engage or empowers the patient to truly engage in self-management and informed decision-making as a member of the care team. And one thing that we pulled from this idea of a partnership of care is the power of valuing the experiences of patients and family members before, during, and after their care. So again, we're really looking at care as a continuum and establishing a partnership of care with the patient as a part of it. This then allows us to make an impact on more of those patient level factors. It enhances clinical encounters, and it even facilitates our ability to address some of those structural factors that serve as sources of care disparities that were shown in the previous slide. And so this equity work can be done from a health system level through healthcare organizational culture and quality improvement. Next slide. So to illustrate this for you, CPCQC was able to apply this model of partnership to our work at an organizational level and support our hospital partners in integrating lived experience through targeted implementation. Because again, we recognize quality improvement and clinical community connections as key to addressing the systemic and structural inequities that influence maternal mortality and morbidity. Next slide. So CPCQC launched its Family Integration to Restore Trust program, otherwise known as F.I.R.S.T, with the understanding that meaningful improvements in perinatal health outcomes are not possible unless initiatives are developed and overseen by the pregnant and postpartum people and families from communities whose health we strive to improve. As is evidenced by the program's acronym, we're really working to prioritize lived expertise and ensure that participants are members of the communities they represent, are diverse in their backgrounds and in their experiences, and then feel empowered to serve as leaders, managers, and evaluators of our work. And this then advances care that is safe, equitable, patient-centered, and culturally appropriate. So F.I.R.S.T is a two-phase community-focused effort to train and then integrate families into QI initiatives. The program aims to ensure that families are active members of the care team and collaborative partners in our work. Solutions to address inequities in care are community-led. Providers possess skills and experience in building relationships with families and communities and understand the historical barriers to establishing trusted relationships. And families are provided with a safe environment in which to engage productively with healthcare providers and other families. Next slide. Phase one of F.I.R.S.T focuses on building community members' capacity and resiliency to partner in their care. Here is where we relieve hospitals of the burden of finding patient advocates and preparing them to then use their lived experience to inform QI. So CPCQC not only carries out the recruitment of lived experience experts, but we also pay for comprehensive QI education and advocacy training for community members. Participants then receive a patient family partner certification. This way we can ensure that the program is mutually beneficial, and we provide a financial stipend in advance of their inclusion into care teams to foster meaningful participation and to address barriers to engagement. Phase 2 then focuses on establishing those partnerships of care. So we empower patients and family members who have completed the phase 1 training to choose to participate in one or more of these family integration services that we provide. For example, our program participants can choose to serve on a CPCQC committee to advise and inform the decisions and direction of our organization's programs. They may serve on the CPCQC board of directors to guide the overall strategic vision of our organization and inform its mission, vision, and values. Alternatively, they may choose to be connected with hospitals directly and provide education to healthcare quality improvement teams on how to effectively engage and care for pregnant and postpartum people, or they may offer direct peer-to-peer support. Next slide. So to ensure success in patient-family engagement, teams should focus on recruitment, recognition, and retention. And in terms of recruitment, first and foremost, we recognize community engagement as deep relational work, given the very personal, life-changing, and at times traumatic nature of the experiences that we're asking folks to draw upon and be informed by. There's also a very delicate nature to some of the more cultural aspects of this work. So what has become particularly important in our outreach and recruitment efforts is ensuring that we have established an authentic initial connection with every person who expresses interest in being involved with our organization. And that often does come about when folks have life-changing experiences and really want to enter into the healthcare field to see how they can make a change themselves based upon that experience. And there are a couple of ways in which we have worked to facilitate community connections. We'll talk a little bit about those on the next slide. But the second focus area is recognition, or what we might generally think of as compensation. We want to encourage teams to think a little more broadly about this aspect of engagement to include co-creation and evaluation of quality improvement projects. So really include patients at the outset and in the design of your work, and show them data, right? Like show them how their knowledge and experiences are being used to inform care. But also think of other forms of recognition, including financial compensation and reimbursement, because while it is the case that many folks will need or prefer to receive monetary compensation, that may not be enough for some folks, and other folks may prefer recognition of a different kind. For example, they may want to be recognized publicly or awarded in some other form. In terms of monetary compensation, though, we as a state PQC offer to all community members who are involved with our organization a yearly financial stipend, again, relieving hospitals of that burden. This ties back to ensuring that we're addressing equity at every level of this work, because by providing those advanced financial stipends, we're also relieving patients themselves of the burden of having to front the costs that may be associated with engagement, or from having to wait for the administrative processes for payments that can take up to months sometimes in larger healthcare facilities or public institutions. And these are the things that, we don't always think about, right? As we're engaged or we're working mostly alongside colleagues who are being compensated through salary to engage in this QI work. And then the last aspect of engagement that we want to highlight is retention. And we've operationalized our commitment to facilitating long-term engagement of community members by, as I mentioned, allowing participants to choose how they want to be involved in our work, and then empowering them to decide for themselves the ways in which they feel most valued. And again, we want, we see the greatest improvements in care when we do the relational work of partnering with patients and family members and establishing trusted relationships. Next slide. So lastly, I want to address a few considerations for ensuring that your system is ready to engage patients and families with lived experience. And the first piece is around education. So bias and sensitivity training for professional members of your team, even perhaps some community engagement training. And this is something that, again, in Colorado, we provide for hospital teams as a PQC. In Massachusetts, if the PQC doesn't provide it, then I'm sure they can connect you with resources for these trainings. And then you want to ensure that within your hospital system, there's a commitment to equity, inclusion, and engagement, because preparing for partnership is not just about preparing patients and family members, right? It's also about preparing providers. Second, you want to ensure that you have strong connections to the communities of patients who you serve. So ask yourselves, do we have the connections to authentically engage? And if not, then assess whether you are appropriately connected to your state's PQC, the Alliance for Innovation on Maternal Health, or some other trusted partner to help you in establishing those true connections to patients and their communities. Even us as a PQC, who is a little more connected to community-based organizations and community members themselves. When we were recruiting for the first program, we utilized a trusted messenger approach. So we put out recruitment calls to some of those community-based organizations who we're connected with, and really encouraged them to do some of that outreach, because when it comes from a trusted source, you're more likely to get patients on board. And finally, there are a host of ethical considerations attached to this work. And I'll say that while you can certainly do it directly through your healthcare system, doing this work through a learning collaborative or QI setting really helps to mitigate some of the risks of harm to the lived experience experts, as well as to hospital staff. In some ways that we at CPCQC have accomplished this is by having patient-provider engagement policies in place. So, when we are having coaching calls with care teams that may include a patient partner, we don't allow hospitals or providers, for example, to be named. And we're able to provide both hospital staff and the patient advocates with some preparation and ground rules beforehand. Again, we also ensure that patients are provided with QI education so that they understand the true purpose of their work and what type of change we come together to achieve. So really helping them to understand that this isn't just about venting, right? This isn't just a venting session, and the information that's helpful for hospitals to improve care includes the details around what went right and what was done well in their experience, in addition to what could have been improved. We also provide patients with education around birth trauma, and we have them complete a self-assessment to ensure that they're ready for patient advocacy and to reduce the risk of re-traumatization. Finally, we have a lived experience expert on staff, which is the role that I fill, to serve as a liaison between hospital care teams and patient family partners. And we do all of these things, amongst others, to cultivate a safe space for engagement. And so I'll just give you an example of kind of what all of this can look like. So we've engaged a patient as part of our quality improvement initiative to reduce primary cesareans. And this patient worked with me quite a bit on her preparedness to engage. So we made several accommodations to ensure her comfort. But ultimately, it was decided that it might be best to give a written narrative because the experience was traumatic. And so I worked with this patient, and the hospital team worked with our QI coach. And the hospital where she gave birth following her experience, they then implemented several changes after they sat down and reviewed this written narrative and really worked on, what improvements could be made. So they implemented improved nurse-patient communication during labor with an explanation of all interventions. Warm blankets were placed. There was a policy put in place where warm blankets are now placed on the patient in the operating room. There's the use of a clear drape, so parents have the option to view birth during cesarean, one-on-one nurse to patient care while in the operating room, and inclusion of the patient's partner in all communication about labor, birth, and infant care. These were all changes in policy and practice, among other things, as a result of her experience, and we were able to share then those changes back with the patient. So she was made aware of how her lived experience was used to improve care. And we've subsequently done work with this patient as well and provided additional training so that this year the patient was able to speak at our SOAR forum. So our forum around that QI initiative to other hospital care teams. Was really, really received well and really a success. Next slide. So I want to open it now for discussion or for questions, and first provide you with our contact information for follow-up. We at CPCQC are always available as a resource if things come up later or you'd like additional guidance or have questions.
Thank you so much, Brace. That was tremendous and terrific. There's been a lot of great commentary in the chat. Before we go into the questions, I wanted to give Kristen Price a moment to also comment. Just before we started, we talked about how we'll have some funding to support a patient family engagement coordinator for Penquin. Just wanted to comment on that. And then also, there are some comments that you made during the presentation that are sitting well with us, and particularly Dr. Job noted she really loved the idea that you were providing stipends up front. That is so creative and so important and helps to, I'm sure, solidify some of the engagement. So I'll turn it over to Kristen to make sort of the first set of comments, and then we'll go into the questions.
Thank you, Audra, and thank you, Brace, so much for such a great presentation. I was taking lots of notes. So we received a 5-year CDC grant last year, which many of you know because a portion of it is supporting this maternal health equity bundle work. But this year we were able to submit a proposal for non-competitive funding to increase the capacity of Penquin. And what we chose to do is to use the funding to support a part-time patient and family engagement coordinator. And I know, Brace, we really got that idea from when Kaylee and Claire met with you and learned more about what CPC QC is doing. So we are going to use that to hire a part-time patient family engagement coordinator, and then support using the rest to support stipends for up to 5 family community members, which we're kind of calling will be the inaugural PinQuin PFAC. And it sounds a lot, one of our vision sounds a lot of what you were thinking. It's obviously we would onboard and train these members, but then also have options of how they can participate. So we envision them sitting on committees for PinQuin, sitting on our board, helping PinQuin make strategic choices, but then also being a resource at some point for our hospital facilities. So being able to provide some direct patient feedback, or as you even mentioned, educating facilities from the patient and community point of view. So we're really excited here, and we'll definitely be, I'm sure, continuing to stay in touch with you to get some additional tips. But thanks so much for what you presented today.
Thank you. And I just want to say, absolutely, I am available always. But also, just I think, the approach that you're taking is a good one. What we've really found, even in working alongside other PQCs and patient family engagement, is that there really is, as Audra mentioned, there's a hurdle that we have to get beyond in kind of doing this work. And part of it really starts with that initial recruitment, bringing someone on staff, having that dedicated personnel and the time and the resources associated with this work, or allocated directly to this work, becomes crucial, we found, to being successful in it. Also, if you can find someone who has lived experience, so who themselves identifies, we all have a lived experience, but someone who identifies as being informed by that lived experience to do this work, then I think you're also setting yourself up for success. I didn't talk about this too much in the presentation, but because I have my own lived experience, really what we do is we, have an initial introduction. I have an initial introduction with every patient family partner who we bring on. And part of that is really just me sharing my lived experience and how I got involved in this work and my work with the PQC. And that becomes important because, again, you really want to be establishing trusted relationships with community members. We don't want to be perpetuating the practice of going into communities, causing harm, right? Or extracting what we can from community members and kind of leaving them without any fulfillment or feeling as though they've in any way been valued. And so just having, hospitals will know this, right? It's called an initial, what we refer to as a warm handoff, usually when we're talking about the continuum of care and follow-up. And so it's sort of like that, having kind of these warm introductions initially with patient family partners. And that really helps also, not only with recruitment, but also with that retention piece that I mentioned. Were there other questions that I missed in the chat, or anything else coming up for folks?
There was also a comment in the chat from Kylie Garver that said, "Thank you, Brace. I appreciated hearing the specific changes that were made at the institution following the patient sharing her experience. It takes courage to share a personal story, and it's good that it resulted in change." I'll turn it over also to Dr. Jock, who'll comment on work in Massachusetts.
Hi, Brace. Thank you so much. I really love the process you have in place in Colorado. And I agree with the person who said that it does take courage to come out and talk about your personal experience directly to the hospital where you receive the care, knowing that you may go back there or not. We recently were in conversation with F.I.R.S.T, which is a nonprofit organization that works around community engagement, but the way they do it is they work with the hospital to get the zip codes of all the birthing people, and then they go out in the community, anonymously find community members who have given birth in these hospitals, and collects a feedback and then shares it back with the hospital. And then they work with the hospital to use those, whatever feedback they receive to make changes, which makes it broader, which provides a broader perspective, and which allows community members to feel even more comfortable sharing their experiences, knowing that, they're not going to be face to face with whoever the providers were. And I didn't know if Colorado was part of that. Have you had any contact with her or heard of it?
No, we have not, but that is another very creative solution to mitigating some of those risks. And as you said, ensuring that patients feel comfortable reporting on their experiences to the hospitals at which they received care. What we have found, and it took us a long time to prepare for this work and to feel comfortable doing it. But what we found is, we kind of take an individual approach to this, because there are some patients who feel comfortable giving feedback to the hospital where they gave birth. There are others who don't. And so we make sure that we are able to fulfill, whatever the patient's family partner's needs, and ensure that we're able to make sure that they're comfortable in this work, particularly for folks who are from smaller rural communities. We found they are maybe less comfortable with sharing those experiences, and so they're able to share their experience with other hospital teams. For example, we don't always put patient family partners in the position of speaking directly to the hospital care team where they gave birth. It is true that actually most times we don't, but we have also found that sometimes it is particularly impactful for the hospital team and for the patient if they're able to speak directly to the hospital where they received care. What we do in those situations, which again tend to be the exception, is we make sure that there are appropriate measures in place to make sure that we're not re-traumatizing folks, to make sure that we're not putting hospitals in a position where there's potential harm. And that's kind of really where having this liaison person comes in and can help kind of mitigate some of those risks.
I'm sorry, I have two follow-up questions. One is, when you are doing that directly with the patient and going back to the same hospital, is DEI involved, or is it just the patient and PQC? And then my second question is, what is the compensation rate? Is it an hourly rate, a flat rate? How are people being compensated?
Okay, and your initial question you asked is who involved?
DEI, within the hospital.
Yeah, and the answer is generally not, and that's really probably only because through the FIRST program, we've not yet engaged hospitals outside of our collaborative. So we've stayed within the realm of working with hospital partners who are part of our learning collaborative, and then we have myself on staff as that patient partner liaison, and then also and so I've received training myself, and then we also have a QI coach who works with us in those situations, who's also received specific training. If we expand the FIRST program outside of our learning collaborative and begin to work with hospitals in a more direct way, I think we'd certainly want DEI involved. And then with regard to compensation, before we started the FIRST program, we did a lot of research around fair compensation for lived experience experts. We worked with our Department of Public Health and Environment on this, and we settled on what turns out to be a $50 per hour rate. But because we offer the payment in advance, we offer that yearly stipend, it turns out to be about $600, $550 to $600 per year. We're a nonprofit, and so we've got some There are some regulations and, IRS rules that we operate within typically. We can't be paying what would be considered volunteers as employees. So that's another reason why it's good to not pay them on an hourly rate. But if we go beyond that $600 amount, then we take these patient family partners on essentially as independent contractors and continue to compensate them. But for the most part, we work backwards and just ensure that we stay within the $50 an hour rate. So we ensure that the workload for these patient family partners does not exceed that, unless they are so engaged that they really want to be more involved, in which case we revisit that on an individual basis. And again, sometimes bring on folks as independent contractors to continue their work.
That's really helpful, Brace. Thank you so much. Any other additional questions? If anyone wants to raise their hand or unmute, or maybe even talk about their own experience bringing on a community partner into their work. Nice. Well, thank you again. We really appreciate it. And we will keep you posted, Brace. We'll talk to you guys in Colorado and let you know how our journey is going. And look forward to seeing our structure measure continue to develop a sea of blue from left to right as we bring in more community members into the work that we're doing, so that we can truly better and best serve the communities that we serve. All right.
I just want to say, encourage really quickly, since you are all moving into this space. AIM has a wonderful program. It's called Lived Experience Integration Community of Learning, and it's really to support the PQCs in doing this work. So I would encourage you all to get involved in that work as well, and have your own support in supporting hospitals. And thank you all again for inviting me.
Absolutely, and thank you for joining us. All right, for the teams, we're going to turn over to some QI teaching. And what I wanted to share was QI teaching from one of our very own partners of PinQuin, which is Dr. Deborah Bingham, who is the founder and lead of the Institute for Perinatal Quality Improvement. And they also are the team and the group that leads our Speak Up Against Racism bias training that we offer to the teams. We can go to the next slide. What Dr. Bingham has created is something called the ABCDEs of QI implementation strategies and tactics. And why I found this important to bring to the group today is because, there was something that had been said at one of our summits, our last summit, where when Dr. Davidson talked a little bit about having improved outcomes and saw an improvement in the outcomes related to implementing the hemorrhage bundle at a hospital in Texas, and a health system in Texas, that someone made the comment at one of the tables that I heard that said something like, how do you replicate what someone's done if all they did was implement at their committees, at their committee meetings, she just showed the data by race, ethnicity, and they already started to see a decrease prior to even implementing other components or structure and process measures of that hemorrhage bundle. And I wanted to make sure that we had a chance to talk about what it means to do QI work, and that lots of experts have thought about this over the years. And there is something called ERIC, which is the Expert Recommendations for Implementing Change and Quality Improvement. And ERIC has this exhaustive list, which is pretty inclusive of all. I've looked at it a few times. I've not seen any other publications add to this list. But what ERIC does is list all of these strategies and tactics for implementing change that have been found to be generally successful. And so there were a couple of publications where experts had looked at this and grouped these and agreed that these were strategies and tactics. Dr. Bingham has grouped them into these areas called ABCDEs. As you can only imagine, with Speak Up being a mnemonic, similarly, she was able to take these ERIC recommendations and create this mnemonic on accountability, buy-in, collaboration and communication, data, education, and structure changes. And so what she's done is taken those ERIC strategies, which is a very long list, put them in various categories, but then she also annotated and added to some of the categories with some strategies and tactics that have an equity focused lens. And so what we've done in thinking about some of the work that has happened is how do we characterize the relevance and significance of how doing that step led to a change. And it wasn't that it was sort of voodoo, to be quite frank. It was actually buy-in and accountability were two ways of, and using data were two ways of really bringing information forward and starting to see a change. Sometimes what we might see is data may be corrected. We can see improvements there. We saw that in our very first MPQC bundle when we looked at early elective deliveries, when it really was just cleaning up the data. So when people are able to see the data by race, ethnicity, you have that. Also was an education for folks to say, hey, here's what's happening and here's how we're performing. But that piece of accountability was really important as well. And so if you go to the next slide, Kaylee, we'll show what some of these are. And so according to Dr. Bingham, accountability includes a number of activities, but one is that we wanted to point out is obtaining formal commitments, really getting leadership to buy in. And she had leadership buy-in as she reported during that summit in the spring that we had to say that her leadership supported her in saying, I'm going to bring this data, and this data is going to show that we have a disparity. And I want you to know that some people may receive it. Well, I'm not sure how the department is going to receive it. And just bringing that accountability, creating change by showing performance reviews of how they're doing as a department was really important also. The second slide, if you want to go to the B, buy-in is mostly around incentives and disincentives. And so this is more around funding and billing and liability laws and capitated payments. So not so much this, but we go to the next slide into C and talking about communication and collaboration. Communicating information, identifying champions and preparing champions is really important to do this work. In that work that she did, she was able to also bring in a coalition of champions among her peers and get peer support in doing this work by presenting the data. As you've heard today from Brace Gibson's talk, involving patients, consumers, and family members is really important, and the communication of the work that you're doing and collaborating to move the bundles forward and identifying which bundles are important to do. So really wanted to lean in and showing that there is some value into and building a coalition of not only your peers locally, but also building a coalition among the patients and consumers out in the communities. We'll go to the next slide. D is all around data. Here we go. And so what she was able to do was provide information to her faculty and her team around data. We also know that we've talked and heard a lot about developing data dashboards and organizing your quality monitoring system so that you can not only identify when there are disparities, but you can also realize the magnitude of those gaps and those disparities, and also monitor for progress as you're putting actions in place to address those gaps. Facilitate relay of clinical data to providers, which is exactly what happened in that space in Texas when they met with their quality team to talk about their different data. All right, we'll go to the next slide. E involves education. Dr. Bingham and her team have been strong partners led by Dr. Jop, working with the state to help support that financially to conduct ongoing trainings. Dr. Davidson did say during her summit presentation that they also brought in components of the equity bundle that was originally created by AIM. And in doing so, they also brought in conversations on bias training into those faculty meetings in addition to this data. So it's another point of clarity around the relevance and importance of the actual strategy that led to a change. And then also one thing that we wanted to highlight was making training dynamic. We really appreciate what Dr. Bingham brings to the Speak Up training, and that she has folks sit down and create a complete action plan, either for themselves or for something they're doing on their own labor unit. And that makes the training very dynamic. All right, we'll go to the last one, which is S, and that's structure changes. And so things that can happen for structure changes is creating a learning collaborative, which in essence is what happened in that space in Texas. They were able to transition their quality team, not only just as a team for review and comment and feedback, but also as a learning collaborative by bringing some education to that group. And then also we want to highlight, develop and implement tools for quality monitoring. And so those are some of the structure changes that we're hoping and trying to help teams to bring in here in Massachusetts by creating an equity team, creating data dashboards, creating systems where you can look at all of your outcomes and processes by demographics. And so developing and implementing these quality tools for monitoring are so key and important. And so that's the last of these slides. You can go to the next slide, Kaylee. I just wanted to just really underscore and share one more time, and I know we have 3 minutes left, and I'll turn it over to Kaylee to wrap up. Just really wanted to share that there are experts who've looked these things over, and there are various strategies and tactics, strategies being more the super categories and tactics being those steps to get to a strategy that show the relevance and value of what we're doing. So please never underestimate just one simple step of bringing data to a group of people to increase accountability, bringing data and education forward. So I'll pause there and turn it over to Kaylee. If there's any comments, we can use the chat to answer any questions or comment as well.
Thank you, Audra. That's such a great point to end on. And thank you also to Brace for her wonderful presentation. I think family engagement and how to do so thoughtfully is one of the things that I've gotten the most questions about since we started this bundle. So I hope you all got a lot of takeaways from her presentation. I'm just going to run through some resources and upcoming events. Caroline will be posting registration links and such in the chat, so please keep an eye on that. Related to Brace's talk today, we've developed Penguin Maternal Equity Bundle toolkits and quality improvement toolkits that are on our website. Each of these toolkits does have a section on family engagement, and we also have a poster that we created with Team Birth on respectful care commitments. So we hope that all of these things can be helpful as you move forward with integrating lived experience into your QI work. We are almost finished with a year of Equity Bundle webinars, which seems wild, but our next one, as we alluded to earlier, is July 18th. It will be on the hypertension process measures that you've been completing monthly, and our guest speaker will be Dr. Ron Iverson. Free CNE and CME credits are available for all Equity Bundle webinars. So when you go to our webpage to view a recording or download our slides, there will be a credit claim page. You just go and you fill out a simple 5-question post-test, and you'll be able to download a certificate. Now for some upcoming events, this Thursday, June 22nd, the Count the Kicks campaign to prevent stillbirth is having a webinar, so you can learn more about the campaign and resources available for providers in having this discussion with your patients. On June 28th, the National Network for Perinatal Quality Collaboratives, of which Penguin is a part, is having a webinar all about teen birth. So Dr. Amber Wyseth, who was a speaker at our Aftershock panel at the summit and is on the Penguin Advisory Board, will provide an overview of the program, and there will be a couple of other state teams sharing how they implemented teen birth. 9 hospitals, 10 actually in Massachusetts have already implemented teen birth. I know many of them are here today. So in case you're interested in teen birth and want an opportunity soon to hear what it's all about, feel free to register for this webinar. Coming up in July as well, Mass Health, the Mass Health Doula Services program has a listening session where you can learn more about this new program coming out from Mass Health. They're using this as an opportunity to gather feedback. So if you have thoughts or questions on this, please make sure to attend. The AIM program has technical assistance webinars every month or so. The next one coming up is how to develop policy to sustain quality improvement initiatives at your institution. So that should be a very helpful one. And also just recently, last week, Dr. Deborah Bingham and Renee Byfield, who conduct the Speak Up bias education, were part of a webinar for AIM on respectful care education for providers. So that just happened, and I will send out the recording as soon as that becomes available. It was a really wonderful talk, and we got several shout outs in Massachusetts for all of our work. So thank you all for making that possible. Just a couple slides to go. I know we're 1 minute over. If you attended our severe hypertension bundle webinars in 2022, or you'd like to watch the recordings, you can do so by August 4th and claim free CME and CNE credits. So make sure you take advantage of that opportunity. Finally, the California Perinatal Quality Collaborative has been having a 4-part webinar series on integrating midwives and doulas and community-based care into hospital care and improving those relationships. So the next webinar is coming up on August 30th. And then ACOG just launched an online mental health training for OB providers. I know mental health is increasingly present in just national media and in the QI space. And so we're really excited to announce these new resources this module was developed with our partners at UMass Chan Medical School. So this work is happening in Massachusetts, which is very exciting. And data dashboards, as always, we have several webinars available to help you complete structure measures. We did these webinars with Deborah and Renee at PQI. These are archived and available to watch for free anytime. And that was my final one. Thank you so much, everybody. There's so much going on this summer. So if you're around, we hope you'll take advantage, and we'll see you in July.